Hello, my dear curious and studious students of surgery. Myself, Dr. Mahesh Chaudhary. I am warm welcoming you in my surgery lecture series. This surgery lecture series contains entire surgery with anesthesia, with radiology, with orthopedic. So stay tuned with us. Let's start our surgery lecture series. Warm welcome, dear students, in my surgery lecture number 56, that is the cystitis. In this lecture, we will cover the etiology of the cystitis, clinical features of the cystitis, investigations, treatment of the cystitis, vesical calculus, that is the bladder calculus, its treatment, suprapubic lithotomy, litholepexy, modern lithotripsy, diverticulum of the bladder and its treatment. All these points we will cover in this lecture. Now start with me the cystitis. Cystitis is much more common in women than in men, probably due to short urethra through which the bacteria is ascends. Cystitis is also compromise the hepatogenous renal infection in rare cases. In men, cystitis is almost always secondary to some other causes, that is the infection of the prostate, enlarged prostate associated with the residual urine, presence of vesical calculus or an ulcerated vesical neoplasm, predisposing causes, that is the presence of calculus, foreign bodies or neoplasms in the bladder, obstruction in the urethra due to the urethral stricture or enlargement of the prostate or prostatic carcinoma or stenosis of the external urinary meatus, presence of diverticulum in the bladder, injuries or disease of the spinal cord, presence of the vesico-ureteral reflux may incite cystitis, malnutrition with lower general resistance. Now the roots of the infections are: first is the ascending infection, second is the hematogenous infection, and third is the lymphatic spread. First, ascending infection from the urethra is the commonest. This is why cystitis is very common in females who possess the short urethra. Escherichia coli, which originates in the bowel, contaminate the vulva and the perineal region. From these regions, they get easy access to the bladder in case of females. Passage of urethral instruments may cause cystitis in either sex, that is the male. Hematogenous infections from kidney may cause cystitis but rare. Lymphatic spreads from the neighboring viscera has also been noticed. These viscera are mostly infected cervix, fallopian tubes, vagina, sigmoid colon, etc. This is also comparatively rare. Now the causative organisms, the most common infecting agents is the Escherichia coli. This is followed by the Proteus mirabilis, particularly in young women, Staphylococcus aureus, Staphylococcus albus, various streptococci, Pseudomonas and Klebsiella. Schistosoma hematobium produces cystitis which may be complicated by stone formation and high incidence of the cancer. Mycotic infections of the bladder is rare. Monilial vaginitis may secondarily infect the bladder. Very rarely, actinomycosis may involve the bladder by direct extension from the lesion in the bowel. Now the pathology, macroscopic features. In acute cystitis, the mucous membrane of the bladder is swollen, intensely red and congested. The normal glistening appearance of the mucous membrane is lost. In chronic cystitis, the bladder may show thickening of its wall with corresponding reduction in the size of the cavity. Now the clinical features. Symptoms. Severity of the symptoms depends on the severity of the disease. First, increased frequency of the urine both in the day and at the night is the most important system. Urgency also a very characteristic symptom of this condition. So urgent that incontinence may result. Pain varies from the mild to agonizing in severe cystitis. Hematuria, pyuria. This is often seen in cases of the cystitis. Now the special investigations. First is the blood examination. White blood count is usually elevated. ESR is also increased. Urine examination usually shows pus cells, bacteria and red blood cells. In case of presence of the associated prostatitis, threads may be seen in the initial specimen, so midstream urine specimen should be taken for the culture and sensitivity test. Third is the X-ray are not indicated unless stasis or renal infection is suspected. X-ray is also required if the patient fails to respond to adequate antibiotic treatment for cystitis and or the infection is recurrent and there is a presence of obstruction. Vesico-ureteral reflux, tuberculosis or calculus. Next is the cystoscopy. It is contraindicated in acute phase but it should be done 10 days later when hematuria is continuing to exclude presence of the vesical neoplasms or stones or the foreign body. Now the treatment. General measures. First, the patient is urged to drink plenty. Alkalinization of urine should be achieved. 60 to 20 gram of sodium bicarbonate may be given for this. Antispasmodics like Buscopan and atropine. may be used. Urinary tract analgesic 100 mg tablet of the phenoxypyridine, the trade name is the pyridium, may be used in the dosage of the 2 tablets thrice daily after meals, provides considerable relief. Local heat, hot sitz bath may ease severe pain and spasm. Then the specific treatment, antibiotics are prescribed according to the sensitivity test report. A few antibiotics are particularly effective in cystitis. These are nalidixic acid 500 mg, nitrofurantoin 100 mg tablets, amoxicillin, trimethoprim and sulfamethoxazole, chloramphenicol, ampicillin, etc. drugs may be useful. Now, the next point of this lecture is the vesical calculus. The incidence, vesical calculus was quite common previously in the 19th century. Gradually, its incidence has come down, particularly in children and adolescents. This seems to be due to the improved diet rich in proteins and abolition of the malnutrition. Now the types. 2 types of the vesical calculi are found. First is the primary vesical calculus and second is the secondary vesical calculus. Primary vesical calculus, which develops in the sterile urine and mostly originates in the kidney, which passes through the ureter into the bladder. Here it becomes enlarged. And the secondary vesical calculus occurs in the presence of infection. This type of the calculus mostly originates in the bladder. In this group may be included another type of the vesical calculus which occurs by deposition of the urinary salts upon the foreign body in the bladder. Dear students, you can see the clear X-ray image of the vesical calculus. Huge vesical calculus is seen on your screen. This is the vesical calculus extracted by the cystolithotomy. Composition of the vesical calculus. Chemically, the primary stones may be earlier of oxalate types, calcium oxalates or uric acid, and the urate types of the cystine type. First, the oxalate calculi moderate size and is usually solitary. Though calcium oxalate is white, yet this stone often looks dark brown or black due to the incorporation of the blood pigments on it. This stone is particularly prone to the cause hematuria due to its spiky surface. Second is the uric acid and urate calculus is smooth, round or oval. The color varies from pale yellow to light brown. Pure uric acid stone is not radiopaque. Cystine calculus is usually associated with cystinuria. It is often radiopaque due to its high sulfur content. And the secondary vesical calculus is mostly made up of triple phosphate, that is the ammonia, magnesium and the calcium phosphate. Now the clinical features. Males are more often affected in the ratio of 8:1. Clinically, 3 types of the bladder stones are noticed: usual type, silent type and masked type. Usual type which gives rise to symptoms, silent type which is asymptomatic. First, the usual type, the symptoms which are usually complained by the patient with vesical calculus like frequency, pain, hematuria, dysuria, acute retention of urine. Second is the silent type, when the vesical calculus rise in the diverticulum of the bladder or in the post-prostatic pouch, it remains symptomless for quite a long time. These stones are usually discovered either by the straight X-ray of the abdomen or by cystoscopy, which is performed for some other purposes. Third is the masked type. In a few cases of the vesical calculus, the symptoms of the cystitis dominate so that the patients are treated in that line and the stone is masked. The patient who frequently comes with the complaint of the cystitis should be investigated thoroughly to exclude the presence of the vesical calculus. Now, the physical signs. Abdominal examination is usually negative except in some cases where tenderness in the suprapubic regions may be elicited. Rectal or vaginal examination should be performed in all cases of the vesical calculus. One may be able to palpate the vesical calculus by the examination if the stone is of moderate size. Bimanual examination, that is the abdominorectal and abdominovaginal examinations. Investigations. First is the urine examination, may reveal the RBC pus cells and the crystals of the stones in the urine. Straight X-ray usually reveals vesical calculus in about 95% of the cases. X-ray radiography should always be performed to know the functions of the status and the status of the kidney. It will also reveal a filling defect in the cystography when the stone is not opaque. Fourth is the cystoscopy. This is the essential to know the type of the stone and to exclude any other pathology like diverticulum, tumors of the bladder. Now the treatment. In majority of the cases of surgery is required to remove the stone unless the stone is very small. The vesical calculus removed by either of the 2 methods. One is the suprapubic lithotomy and second is the lithotripsy. Third is the modern lithotripsy. Suprapubic lithotomy, this is the particular performed when the case is contraindicated for the lithotripsy. The method of the suprapubic cystotomy is very old. The lithotripsy technique, the method consists of crushing the stone by means of a lithotrite and subsequent evacuation of the fragment with the special evacuator. And the third is the modern lithotripsy. This technique is used nowadays in many specialized units. Energy is generated by the mechanical means using a steel ball which is fired in a closed chamber of the proximal end of the endoscopic probe. This helps in breaking the stones into the small pieces. The endoscopic probe comes in 3 different sizes. Usually the largest size is 9 French is used for the bladder calculi. After the patient is cystoscoped, the probe is placed close to the stone and fired. One must be very careful not to damage the bladder wall. This is the modern lithotripsy. Dear students, here is the image of the cystoscopy. You can see there is the stone, and by the modern lithotripsy, the stone is fired and fragment is being made and removed by the cystoscope. This is the lithotripter. You can see on the image. This is the removal of the pieces of the stones by the lithotripsy. This is the litholepexy. The bladder stone is grasped between the 2 jaws of the lithotrite before crushing. This is the litholepexy. Next, the point is the diverticulum of the bladder. It is a pouch-like opening which communicates of the bladder through a narrow mouth. Now, the types of the diverticulum of the bladder is usually 2 types is detected. One is the congenital diverticulum and second is the acquired diverticulum. There is a third type which is known as the traction diverticulum also. First, congenital diverticulum. It is an extremely rare incidence and is usually seen in the infants and young children. Congenital diverticulum is situated in the midline near the apex and represents the unobliterated vesical end of the urachus. Second is the acquired diverticulum. This is usually noticed in men over 50 years of age. It is uncommon in women. It is usually associated with some form of urethral obstruction, that is the contracture of the bladder neck, benign enlargement of the prostate, fibrous prostate, urethral stricture and the congenital walls of posterior urethra. Such diverticulum usually occurs on the lateral wall of the bladder above and to the outside of the ureteric orifice. Dear students, here is the image you can see on your screen is the diverticulum of the bladder clearly seen. The opening is the narrow. This is the another image showing the diverticulum of the bladder, and this is the ultrasound image showing the multiple diverticulum of the bladder is clearly seen. The basic cause of such acquired diverticulum is the rise of the intravesical pressure due to the obstruction into the urethra. Normally the intravesical pressure is about 35 cm of water at the commencement of the micturition. With increase in the intravesical pressure, the mucous lining between the muscles bundles protrudes out to form small saccules. In the beginning of the wall of the saccules is formed by the course of the bladder. But as the sac enlarges, the muscle become thin out over the fundus and may eventually disappear. Now the complications of the diverticulum are: first is the infection due to the disappearance of the muscles in the wall of the sac and the stagnation of the urine continuously in the diverticulum cavity. Second is the formation of the calculus due to the stagnation and of the triple phosphate and in the bladder and in the diverticulum. The infection, the condition for ideal for the formation of the calculus. Third is the obstruction. Fourth is the carcinoma. Within the diverticulum, there may be the squamous cell metaplasia and leukoplakia, which occurs about 20% of the cases, and formation of the carcinoma, development of the carcinoma. Now the clinical features. As majority of the diverticula of the bladder are of the acquired variety, the clinical features of this condition only will be discussed. About 90% of the cases are the male above 50 years of the age. There is no typical symptoms of the vesical diverticulum symptoms due to the cystitis dominate. So now the special investigations, excretory urography should be performed in all cases to exclude any obstructive features of the diverticulum and to know the condition of the kidney of the affected site. Second is the retrograde cystography may be acquired when the excretory cystography fails to produce the enough concentration of the dye in the bladder to delineate the diverticulum. And third is the cystoscopy. This is a very useful means to diagnose the diverticulum. This clear-cut hole of the diverticulum, which is usually of the diameter of lead pencil, in very clearly seen through the cystoscopy. Fourth is the ultrasonography. This is the non-invasive useful method to diagnose the bladder diverticulum when other methods have been failed to contraindicated. Now the treatment. Unless the diverticulum is quite small and uninfected, there is no evidence of the urethral obstructions, operation is justified. And operations in the diverticulum of the bladder are: first is the traction diverticulum of the bladder. When the portion of the bladder becomes a part of the contents of the inguinal or femoral hernia, it is called as a traction diverticulum. About 1 to 2% of the inguinal or femoral hernia contains such diverticulum of the bladder. This condition is relatively more frequently seen in the femoral hernia and in direct inguinal hernia. Clinical features. The only characteristic history a patient may give is that the remains unsatisfied after micturition until or unless the exerts pressure on the hernia to push more urine out. Dear students, here is the end of our surgery lecture number 56, that is the cystitis. Thank you.